Welcome to the Using SSRIs in Pediatric Primary Care webinar provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the PA chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health and the Children's TIPS program, a telephonic psychiatric consultation service program at Children's Hospital of Pittsburgh and funded by the PA Department of Human Services. This webinar series aims to expose you to a primary care-based selective serotonin reuptake inhibitor, SSRI, protocol for the treatment of anxiety and depressive disorders in children and adolescents. I am Renee Turchi, a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative. This webinar is recorded. The recording is available on both the Pennsylvania Medical Home Initiative and Children's TIPS websites and will be posted on the University of Pittsburgh Internet-Based Studies in Education and Research, ISER website. For CME purposes, please be advised that both Dr. Schlesinger and I have no disclosures to make. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or the policies of the Pennsylvania chapter of the American Academy of Pediatrics or the funders. Please note, now allow me to introduce Dr. Schlesinger. Dr. Abigail Schlesinger is an adolescent and child psychiatrist with an interest in increasing access to quality behavioral health and developmental services for children and families. She was instrumental in the development of Children's Community Pediatrics Behavioral Health, CCPBH, a service that embeds therapists and psychiatrists in pediatric primary care. CCPBHS has won local, state, and national awards for efficiently improving access to care. Dr. Schlesinger has been appointed Clinical Director, Community-Based Services, Behavioral Science Division at the Children's Hospital of Pittsburgh, and is leading the integration of developmental, behavioral, and community resources. She is the Medical Director of Ambulatory Integrated Behavioral Health for WIPIC, and is the Medical Director of the Children's TIPS, the Telephonic Psychiatric Consultation Service Program at the Children's Hospital of Pittsburgh at UPMC. We are delighted to have Dr. Schlesinger present on this timely and important topic for primary care clinicians. Dr. Schlesinger, thank you, and please begin your presentation.
Thank you, Dr. Turchi, and thank you, AAP and the Department of Public Health for helping to support this series. I'm delighted today to speak to you about a protocol for how to use selective serotonin reuptake inhibitors, or SSRIs, in pediatric primary care. I created this protocol along with colleagues at the University of Pittsburgh in response to multiple requests about how to initiate medicines once you have decided you have a child that needs treatment with a medicine. And the basic objective is to be exposed to this protocol. Again, I've done another training on how to identify depression, and there are many resources online on how to identify anxiety and depression in primary care, but this protocol is about once you've made the decision to start an SSRI. So the question is, what kids are we talking about? And I'm not going to go in depth about how to diagnose depression or anxiety in primary care, but when I pose this question to many of my colleagues, they're able to name multiple children that they've treated from young ages up through to their 20s who have extreme anxiety, extreme depression, maybe getting treatment in the community but can't get access to a psychiatrist. And they feel that medicine is needed, but a psychiatrist is not available for a long time. So I would ask you to, for yourself, picture who those children and adolescents and young adults might be that you treat, and when you think about who to start an SSRI. So in addition, there are several factors that you can use to think about who to start an SSRI for. So for a child that has depression or anxiety, severity will determine when you start medicine. Obviously, a mild case of depression or anxiety may respond to minimal interventions such as psychoeducation or getting people to simply move around more, exercise. Moderate and severe illnesses may require medicine treatment or may get better quickly with medicine treatment. Another common scenario that happens very pragmatically in primary care throughout Pennsylvania and the U.S., probably the world, is that you have children that are in therapy, can't respond to therapy, have trouble engaging in therapy, or just can't get to therapy. We do know that a combination of therapy and medicine is the evidence-based intervention for moderate to severe depression and anxiety disorders. So we always recommend a combination of therapeutic intervention that is non-medicine in addition to medicine. But there are times when you start medicine, even if therapy is not used, either because it's not available or because the child can't engage in it. The other thing to remember is that increasing the intensity of treatment can always help boost a response to treatment. So what I mean there is if you have a child in therapy once a month for 12 months and they're not getting better, if they have mild to moderate depression or anxiety and they've made some slight response, I might recommend increasing the frequency of therapy because that may put them over the top. But you could also increase intensity of treatment by adding medicine to therapy. So there are several ways in which you increase the amount of treatment you're giving to someone. Medicine is only one of them. So this protocol is only a roadmap, and in fact, it's a not all the signs on there can you read. People that are treating depression and anxiety in primary care, physicians, PAs, nurse practitioners, psychiatrists, we should all have a team working alongside of us. Because when things don't respond as you expect or a child doesn't get better as well as you'd like, your team can help improve the trip to make the protocol effective. So this is the overall protocol, and we're going to basically work our way down from initiation to first SSRI check, second SSRI check, third SSRI check, and then what happens in maintenance. We'll spend the majority of this session getting actually just to the first SSRI check, since that is where a lot of the work needs to happen. And again, this isn't going to be a comprehensive lecture on diagnosis. I would refer you to other resources for that if you'd like it. So the initiation check can be broken down into 6 pieces. Most of this, should be pretty self-explanatory. You want to validate the diagnosis and safety, review family history, complete the consent or assent, clarify goals, expectations, and safety plan, start the medication, and schedule a follow-up. You'll note that I have schedule a follow-up in almost every slide related to these checks, because that is really the key of making sure that people get evidence-based treatment and that they get better, is scheduling a follow-up to make sure that people have gotten into remission before you end treatment. So validate diagnosis and safety. Now we're going to be going right instead of down. So these are the parts of validating diagnosis and safety. Just as in any other medical condition, you want to review the workup and make sure that you considered medical diagnoses and comorbid psychiatric conditions. In my experience, primary care doctors are very good at making sure that medical diagnoses are not getting in the way. They're looking at thyroid conditions, anemia, as well as other conditions that can mimic depression and anxiety. In addition, it's important to work up comorbid psychiatric conditions as well. So once you confirm the diagnosis, which you can do by using behavioral scales, reviewing information from therapists if they see it, asking questions about individual diagnoses. I put some specific behavioral scales there for those of you who don't know which behavioral scales to use. These are not the only ones out there, but they are all free and well established in primary care. The SCARED has a parent and child version. The child works for 7 to 18-year-olds, and it is for anxiety disorders. The GAD-7 is for over 13 and over 18, and that's good for anxiety. And the PHQ-9 or the PHQ-9A is for depression. These are nice tools that can help you consider diagnosis. You should additionally ask questions. And then you should consider comorbidities that complicate treatment and assure that the child is safe. Notice that I'm doing this long before I start medicine because suicide is a part of behavioral health workup for any child, regardless of whether they're starting medicine. So we're going to work through these pieces of the initial visit, which are really an important piece of initiating medicine. So consider comorbidities that complicate treatment. Why do you do that? Because if you don't consider them, treatment's not going to go as expected and kids aren't going to get better. So bipolar disorder. This is vital, and most people know to worry about bipolar disorder but aren't exactly sure how to consider it. So you want to assess personal history, of which I'll give you a more specific way to do that. So has the child had any episodes of mania? And we'll talk about that in the next slide. The other comorbidity that may complicate treatment is autism spectrum disorder. So many children with autism spectrum disorder do receive SSRIs for anxiety or even depression, but they don't respond classically, and they have specific types of non-medicine therapy that can help assure that treatment helps better. The other thing is, as many of you may have experienced this, is that autism spectrum disorder behaviors, such as repetitive recurrent interests, can look like, quote, anxiety behaviors. And you have to be very careful to not be treating something that's actually a core feature of the ASD, or the autism spectrum disorder, because no medicine is going to help that. The other important comorbidity is trauma, and whether or not there's acute or chronic trauma. Some people have been through so much trauma that it just becomes a part of their world, and they won't tell you about it unless you ask very specifically. So I very much encourage people to ask whether kids have been traumatized by anything. And if a recent trauma has occurred, or if there's any chance that the trauma is the primary driver of the behavior, that before you initiate medicine, you assure that they're getting trauma-informed, better in care, and better even yet, something like an evidence-based treatment for trauma. And certainly substance abuse is vital, because no medicine is going to, such as an SSRI, is going to make behaviors associated with substance use get better. You can always consider screening for substance use, which the AAP recommends doing starting at age 11. Eating disorders are another important key to consider. Many youth with eating disorders, and adults frankly, have very many anxiety symptoms and even appear quite obsessive compulsive. But if a child or adolescent or adult is not getting enough food to feed their brain, they cannot get better from an SSRI. So what we often say is medicine won't work if you don't have enough food to feed the brain. And then finally, suicidality. I think about this separate than individual diagnoses, because it is something that you need to consider for all youth that you're treating. And you want to assess current suicidality, which a PHQ-9 nicely assesses, and past episodes of thinking about or trying to harm or kill yourself purposely. And then ADHD and ODD. These diagnoses do co-occur with anxiety and depression, and sometimes can even look like anxiety and depression. And you want to consider Vanderbilt's, which we talked about in another of the webinars if you want more information about how to work up ADHD and ODD. So, screening for bipolar disorder. There are many questions you can ask about bipolar disorder and mania, and in another webinar I've talked about the specific symptoms of mania. But if you're simply screening for bipolar disorder, this is something you can ask. Was there ever a period of time for more than a few days that you or your child didn't need sleep, was on top of the world, and significantly different than usual? I actually recommend that people practice this sentence so that it comes off the tongue very easily. Note, if they answer yes to this question, it should be a clear change from baseline. Mania, which is what this is screening for, should not be their baseline behavior, such as the opposite would be ADHD, that they're always very busy. This should be a clear change from what their usual day-to-day behavior is. Also, the child should be energetic during the day, not need a nap, not go to bed early, not catch up on their sleep very quickly. And there's the most concern for bipolar disorder if the child was euphoric, i.e. more happy than normal, or grandiose, felt that they were special or had special powers, and there's no reason for it. I often say to parents, if it's the day before a holiday and they had more energy, didn't need to sleep more, and was on top of the world, that's probably not a positive screen for bipolar disorder. That's probably because it's a holiday they were excited about. Safety. Again, safety should be assessed in all children with depression and anxiety. And for those of you who don't know, it's the number two cause of death in the U.S. and has actually crept up to the number one cause of death in many states in the U.S. in the 10 to 24-year-old subset. And it's not just kids with depression and anxiety, it's also kids with ADHD, ODD, impulsivity that are at risk. And many kids actually contemplate suicide. And one report said that up to 9% have attempted at least once in the last year. So many kids may be thinking about suicide. You're not going to make them think about it by asking about it. You're going to understand it, which is really vital to move on towards treatment. So the risk assessment. You want to begin with general questions. Have you ever thought you would be better off dead, or your family would be better off without you? This is called a death wish. This isn't straight suicidality. It's a part of the continuum, but it's not the most extreme. And up to 20% of kids may have had a death wish at some time. You then want to progress to more specific questions. Have you ever had a plan or a means to carry it out? These are much less common. Giving away possessions is also something that can be a harbinger of risk, also much less common. But notice how I progressed from general to very specific questions about have you ever had a plan, have you ever had times that you thought about killing yourself. It's very important to ask directly. If people had thoughts, they will tell you if you ask them directly, and you won't give them more thoughts. You could also normalize. So, for example, many children who are feeling down or depressed describe having thoughts that they don't want to be alive. Have you ever felt this way? This is not saying that it is good to have thoughts of killing yourself. This is saying that it could be normal for some kids to have thoughts. You then want to stigmatize acting on the thoughts. The attempt of acting on the thoughts is what you want to stigmatize. So once you've assured safety, you want to review family history. And for this, you also want to look at bipolar disorder and response to antidepressants. And you can ask about bipolar disorder by asking if a family member has had mania, has been treated for bipolar disorder, or you could ask the question such that I wrote before for the child straight to a parent. I also ask about response to antidepressants. Not only because there is a genetic component of responding to medicines. If a mother or father responded well to an antidepressant, their child may be a little bit more likely to respond to that. But more importantly, if a mother or father or close relative responded poorly to a medicine, parents are much less likely to actually give the medicine you prescribe if they had a bad experience with it. So in family history, I ask about response to antidepressants if I'm thinking about starting an SSRI. Then you should get consent or assent. Whenever you start an SSRI, you should discuss the risks, benefits, and alternative treatments with the parent, and the parent should consent. I also then speak to adolescents and get their assent, meaning that they also agree. And I try to get children to agree, too, as an effort for them to participate in their treatment and realize that they are truly a part of treatment. The adolescent assent piece is really important because adolescents that don't feel like they're a part of a treatment also will not usually take medicine. And then you end up with a fight about medicine rather than taking something that could potentially be very effective. So what are the key components of consent or assent? You want to word about side effects. And for me, I tell people that I warn them about more common ones that will probably go away if they're not too bothersome, if they occur at all. And then rare and concerning side effects, like suicidality, mania, or serotonin syndrome. Another side effect that I often speak about is called activation. This is when some kids get increased energy during the day, but have no trouble with sleep at night. So they don't look manic, but they're energetic and more active than usual. And I warn people about that because if it happens, they'll think it's mania and want to stop the medicine. I do tell people that if they think mania or serotonin syndrome is occurring or suicidality, that they should call and get help quickly to determine what to do next. Although certainly suicidality is not a reason to stop medicine, since suicidality is a component of the psychiatric condition. And since these medicines take 4 weeks to work, if they had suicidality before, they may continue to have it for the first 4 weeks after medicine is started. Here are some common SSRI side effects. I often talk about the GI effects in order to educate people about the presence of receptors for SSRIs, which are predominantly in the brain, the spinal cord, and the gut. This is why young kids or even adults might describe butterflies when they feel anxious or down. Any of those GI side effects may go away. Often, if they do occur, go away quickly. Other side effects such as headaches, bruising, sweating, lightheadedness, nervousness, I tell people about and ask them to give me a call if they happen. The headache, sweating, lightheadedness, nervousness, sleep difficulties may also go away with time. I make sure to warn boys about sexual dysfunction. I discussed the potential risk of suicidal thinking and the precipitation of mania. It's important to talk about suicidal ideation because the black box warning got a lot of press, and they will get information about it when they get the medicine. It's based on a 2004 FDA review of reported adverse events in 23 clinical trials, which involved 4,300 children and adolescents with 9 different medications. I'm going to give you a little specific information about this so you all can understand a little bit more about the black box warning. These studies use 2 different measures for suicidal thoughts and behaviors, and the FDA clumped the thoughts and behaviors into one term, meaning suicidality. So the first way that they measured thoughts and behaviors was an event report. That meant that someone that was in a study, and these were retrospective, and someone had suicidality, someone had to make a report of it. There was less control of these event reports and perhaps even less standardization to what got reported as suicidality. In the second measure, which occurred in 17 of the 23 studies, there were more standardized forms which questioned suicidality at each visit. The second measure is actually considered more acceptable, but they included the first measure as well in the review. So remember we talked about that 2 types of warnings. So the studies that are of ways to assess whether or not there was suicidality, Studies that used event reporting noted that 2% of people who received placebo expressed increased suicidality compared to 4% on the medication. So this is a very low difference. In fact, the confidence intervals are barely significant, but it is a slight difference. When you break the data down further, it's notable that studies that use those standardized forms and question suicidality at each visit actually demonstrated a slight reduction in suicidality for the medication group. So it's interesting that we ended up with a black box warning despite the fact that the data was actually not as consistent. I think one of the reasons the black box warning was put into place was concern in the field, the psychiatric field actually, that people weren't talking about suicidality enough, and because SSRIs were perceived as so safe, people were given SSRIs without a discussion of the risks and benefits of treatment, certainly the initiation of black box warning resulted in more discussion of suicide. What it didn't, it also resulted in some increase across the world. Everywhere the use of SSRIs went down, suicidality went up. It's also interesting to note that in the 4,300 reviewed cases for this meta-analysis, there were actually no completed suicides, which the way the black box wording was worded made many people think at first that these caused suicide, that medicines caused suicide. There was never any evidence that these medicines caused suicide. So this is one way you can talk about the black box warning. If you've never done it, you could even read it directly to someone. And I'm going to read it now. Less than 2% of kids who start an SSRI will see an increase in suicidality, often suicidal thoughts and thoughts about self-injury. I'm recommending this medication because the benefits of treating this depression or anxiety far outweigh any risk associated with increased suicidality. But because we take behavioral health seriously, I will follow up with you closer while starting medicine to make sure that you are safe. That last sentence is very important, and again goes back to the concept of follow-up. I'll remind you again that these medicines can take up to 4 to 8 weeks to work, and certainly most don't have a therapeutic effect before 4 weeks. So if a kid has a depression that's getting worse and you start medicine, they're going to continue to get worse for 4 weeks. And they need to be monitored to make sure that they don't become hopeless. So the next part of the initiation phase is clarify goals, expectations, and safety. So this may seem basic and or something that doesn't often happen in primary care, but I think many people do it without thinking about it explicitly, and I wanted to pull it out so that, because I think this really can make the difference between treatment going well and feeling frustrated as a provider and or family. So a goal is very clearly and simply, what does the family or child want to get out of treatment? and does what they want fit with what you think the intervention will help with. So in a sense, you want to make sure that their goals are aligned with the treatment you're recommending. For example, if a family comes in and says that their child has been a B student their whole life, and now they're depressed and they're still a B student, and they're hoping that if you treat their depression, they'll become an A student, those are not aligned expectations. And I think that there's a lot out there about psychiatry and medicines that may confuse people. So being very clear about what they expect and whether or not you expect the medicine to help with what they want really can help to make a better treatment alliance and a better treatment outcomes. So it's also important to clarify the roles between the provider and the patient, and the parent. So the providers in the practice have a job, and I actually work with a number of providers that say this outright. So, our goal is to help design and support the treatment plan that includes evidence-based intervention. That's what a provider helps with. And a provider maintains confidentiality with caveats, meaning I'll keep the information your child tells me confidential unless they say something that makes me think they're at risk of harming themselves or someone else. And my goal as a provider is also to help children and adolescents get better. And then there's the parents and the patients. They also have a role in treatment, which if you talk about at the beginning can help so that they don't inadvertently fall out of treatment before the child gets all the way better or when they're in maintenance. Their role is to participate in treatment, help design and support the treatment plan, and speak up if things aren't going well. So finally in this category is the expectations of treatment. So again, something to talk about before you even start medicine. Getting better is going to take time. SSRIs can take 4 to 12 weeks at the therapeutic dose to see a full effect. For your information, most of the data on depression suggests that 4 weeks is when you begin to see a therapeutic effect, and for anxiety, the improvement can continue for up to 12 weeks. The dose may need to be adjusted over time. So the first dose you start may not be the dose you end up on. It also means that you need to monitor the response to treatment over time. So this isn't like many treatments that children may have had, if they've had any treatment up to this point, where they're prescribed a single dose of antibiotic and that's expected to treat the ear infection. This is something that takes monitoring and that you may need to change the dose over time. And that again, treatment always works better if you participate in therapy. It's something to remind people up front, especially if they're reticent to therapy. I return to this if they're reticent to engage in therapy and don't respond to treatment. I can remind them, as I said, treatment works better if you participate in therapy. Are you ready? And that's something that you can do at second or third visits if they haven't initiated therapy at the beginning. So, and you don't let them leave without a safety plan. And I do this before I give them a medicine and talk about the specific medicine. There are many ways you can do a safety plan. This is a very bare bones one, but will do the job. One is to have the child name coping strategies that they can use if they're feeling like they want to harm themselves. Number 2 is to have them write down at least 2, preferably 3 adults who they will contact if they're feeling distressed and unable to use their coping strategies. And then the third thing is to write down emergency numbers. It is vital to write the plan down so everyone knows what it is. I also suggest and often have children put the plan in their put the phone numbers in their phone as we talk so they know how to call them. Some children are worried about putting emergency numbers in their phone due to stigma. For those, they don't need to call it the crisis line. They can call the phone number whatever they want it to. It's also important to share the safety plan with the family members, especially with the ones that are on the safety plan, because they need to know that they're the person that will be contacted if this child is feeling suicidal and is unable to use coping strategies. It's important that that contact person not be another child, and again, that that person know they're on the list. Finally, you get to the phase where you can start medicine. You can increase medicine weekly. You can start at the typical starting dose or the low starting dose, which you will see in the slide to come. I often personally start at low doses for kids with a lot of anxiety, somatic symptoms, young kids, or kids with developmental concerns, because they don't respond as classically as those older with depression. So, factors to consider when choosing a medicine. Fluoxetine or Prozac has the most data of any of the SSRIs, although sertraline has more data for anxiety. If you have any concern about bipolarity, don't use Prozac or fluoxetine. And this is not because it's going to make people more manic, but because it has a very long half-life of both fluoxetine and its metabolite. So it could remain in the system for 5 weeks or more after you stop medicine. So if someone would happen to get manic, it's very hard to remove from the system. Also, factors in choosing a medicine is Celexa or citalopram has histaminergic properties, like a little bit of sedation, which might help some kids at night, and it has been shown in some uncontrolled trials to help with belly pain, which is a frequent comorbidity of kids with depression, especially younger kids with depression and anxiety. So, as I spoke to before, I'm going to walk you through the SSRI titration schedule. There are many different antidepressants, but these are the 4 SSRIs, or selective serotonin reuptake inhibitors, that have the most data for the treatment of depression and anxiety. You'll notice that paroxetine or Paxil is not on there, and it is not on there because it does not have, it actually has, there's reason to believe that it is not effective in kids, that it should not be used in kids. So even though it's quite effective in adults, and there's some data in teens for certain conditions, we generally tend to not start with it in children and adolescents. The typical starting dose, which is that 3rd column there, is what you'll often see if you look this up in Hippocrates or in other online places. And it's 10 for fluoxetine, 50 for sertraline, 10 for citalopram, and 5 for escitalopram. I want to pause there to note how much higher the doses are of sertraline for the equivalent effect. This is really important so that you don't have people started on sertraline that end up on very low doses. So I actually call this out directly to kids and adults when I start sertraline and say, for example, we're going to start with 50 milligrams. We're going to increase by 25 milligrams a week, which is that typical escalation amount on the other side. And the typical effective dose is going to be 100 to 150 milligrams. But that it's not uncommon that some children may go to 200 milligrams. And you could have the same conversation for fluoxetine, citalopram, and escitalopram. So I spoke earlier a little bit about half-life, and here's the information and sort of the specific information about why I don't generally recommend starting fluoxetine for a kid that you're worried about mania. Obviously, you wouldn't start any SSRI if you thought a child currently had a manic episode, and you'd be leery if you thought they actually had a full-blown manic episode at any point in their life. But oftentimes, I'll have pediatricians call me stating that they've had that there's a family member that has a diagnosis of bipolar disorder that's unclear, or that there's a family member that's been treated with a mood stabilizer, and it's not clear whether or not it's been treated for mania or bipolar disorder. We also have children that I've seen, that many of my colleagues have seen, that one family member that's relatively close does have a manic episode, but this child's never had anything even remotely like a manic episode. And I have had worked with pediatricians that are comfortable starting an SSRI in that situation. I definitely recommend not starting with fluoxetine. You'll notice that both all of sertraline, citalopram, and escitalopram have significantly reduced half-lives compared to the others. And again, notice the variability in the dose ranges from fluoxetine all the way down to escitalopram. I put this information here to compare the sort of pediatric approvals and data. We know in psychiatry that there are some very good studies, randomized controlled trials, as well as things that have approval. And As you can see, fluoxetine currently has the most high-quality data and approvals, being approved for major depressive disorder, OCD, and having high-quality RCT data for MDD, whereas sertraline has high-quality data for anxiety and is approved for OCD. We know there are a lot of similarities between these SSRIs, that fluoxetine, sertraline, citalopram, and escitalopram have many similarities in terms of their impact on outcome, which is why many people use citalopram, even though you can see it does not have any approvals or any high-quality RCTs yet. It's getting harder and harder to fund high-quality RCTs, and citalopram, as you'll hear about soon, has some other concerns that have been mentioned by the FDA, so it's unlikely to have increased data, but it is not an inappropriate medicine to use for children despite that. I included fluvoxamine on here, not because I recommend that pediatricians use this as their first-line medicine, but so that you can see that it does have the indication for OCD, so this is something that you may see used by psychiatrists when a child has not done well with treatment. Clomipramine, in a similar fashion, has great data for OCD, and if people have failed other medications, this is a go-to in psychiatry. And I included imipramine and clomipramine to show that they also have the FDA indication for enuresis, which many of you, I'm sure, know. So, serotonin syndrome. The fact of the matter is that full-blown serotonin syndrome is quite rare, but you do need to know what it is. There's been a lot more excitement about serotonin syndrome in the last few years, and if a patient is using more than one serotonergic agent, they may get information from their pharmacy. Your electronic medical record may tell you that these things are contraindicated together. You can prescribe more than one serotonergic agent together, but if you're going to do that, you better warn people, because if you don't, the pharmacist will, and tell parents and patients to call you if they're concerned about agitation or restlessness, which is one side effect that can be a natural side effect of SSRIs, but could also be a sign of serotonin syndrome. The common offender for serotonin syndrome that I worry about is Imitrex, and since headaches can be both a part of depression and anxiety, can be treated with Imitrex, and you also treat these children with SSRIs. It's important that if people are having headache flares, that they not go over the amount of Imitrex that's been recommended. So I put some more information about serotonin syndrome just so everyone can feel educated about it, so that when you start SSRIs, you feel confident that you understand what it would be if it happened. And these are the typical signs of serotonin syndrome, and not just the agitation or restlessness, but rapid heart rate, confusion, dilated pupils, loss of muscle coordination, muscle rigidity or hyperreflexity, heavy sweating, diarrhea, headache, and shivering. One of these symptoms alone is not a sign of serotonin syndrome. In fact, occasionally people will get diarrhea when they start SSRIs, simply because there's so much serotonin in the gut, and it has nothing to do with serotonin syndrome. It's easier to remember serotonin syndrome if you think about what the signs of severe serotonin syndrome are. So in these cases, you're looking at high fever, seizures, irregular heartbeat, and unconsciousness. So if someone presents with a high fever and signs of serotonin syndrome, you're more likely to want to see them emergently. By the time they get to severe serotonin syndrome, they should be in the ER and receiving support. And severe serotonin syndrome comes along with spontaneous clonus, or inducible clonus plus agitation or diaphoresis, ocular clonus plus agitation or diaphoresis, tremor plus hyperreflexia, and hypertonia plus temperature above 38 degrees Celsius, plus ocular clonus or inducible clonus. You're unlikely to see severe serotonin syndrome in the office. I have been treating adolescents with SSRIs for 15 years now, and have not had one of the children that I started in an outpatient basis have severe serotonin syndrome. But it's important to know what it is, because if it occurs, you need to pick it up quickly, like other severe medical conditions. And also, so you feel educated, what the symptoms of mild, moderate, and severe. And notice in mild, which is hypertension, tachycardia, mydriasis, shivering, tremor, myoclonus, and hyperreflexia, you just continue the offending agent. You support via stabilizing vital signs, cooling, and measures, and you can use a benzo for mild agitation, fever, hypertension, and tachycardia, and you observe for 6 hours. So the other thing that may come up on your EMR systems, or that the pharmacist may warn your patients about, is QTC prolongation. The FDA came up with a black box warning about QTC several years ago, and basically said, don't go over 40 milligrams with Celexa, both because of increased risk of QTC prolongation, but also because they found insufficient evidence for efficacy for depression. So this means as a pediatrician or a primary care physician, I would not recommend going over Celexa 40 milligrams for depression or anxiety. There may be specialists for OCD or for anxiety, or even child psychiatrists that go over 40 milligrams to treat OCD or other severe anxiety conditions. But really, there are enough options that as a primary care physician, I would not recommend doing it. Even though the risk of QTC prolongation is not entirely clear, and we used this medicine over 40 milligrams for many years, I would not recommend doing it from a primary care setting. And then also you need to be careful with drugs that have QTC interactions if you're using Celexa, and warn parents. The other thing that you may hear about is the drug-drug or hepatic or CYP interactions. And it's important to know the difference between these. So if your EMR warns you that there's a QTC interaction, that doesn't mean there's a CYP or drug-drug interaction. They could be different. If there's just a hepatic interaction because of CYP enzymes, you just need to go slow if using two of these medicines together. Also remember that EMR, which I use Epic, but there are many other electronic medical records out there. If they tell you there's a potential interaction, it doesn't necessarily mean that it's a severe or even proven interaction. It could be a theoretical interaction. So simply because something tells you there may be an interaction doesn't mean that two medicines can't be used together. It does mean you should do some additional homework. And if the child has Medicaid, you can certainly call Children's Tips and we'll walk you through it. If you're in Western Pennsylvania and they have UPMC or CHIP, you can also call us and we can walk you through the different interactions. Or you could use any of your online services. A couple other pearls, what citalopram is metabolized by, which is 3A4 and 2C19. So co-administration with an inhibitor may increase the serum concentration of citalopram and increase the risk of QTC. So if you have anybody on one of these inhibitors, the FDA actually recommends that you not go above 20 milligrams of Celexa. And again, this interaction is largely theoretical based on metabolic pathways of prescribed medications, and the clinical significance is unknown, but the FDA has said that you should be careful with Celexa in the CYP2C19 inhibitors. And there it goes, largely theoretical. So I wanted to give you a specific example. Why I put this here is this is a common specific example, and I wrote it out very specifically so that I get it right. So for patients taking citalopram or Celexa 40 or escitalopram, and in combination with any PPI or oral contraceptive. So those are the common things we're seeing, right? So if you treat adolescents or young adults, you may see oral contraceptives, and certainly we see a lot of PPIs these days. So the two can be continued. So Celexa and either of those medicines can be given together, but you need to make sure there's no history of structural heart disease, no personal or family history of sudden death or prolonged QT, and a discussion with the patient regarding the risks and benefits of alternative therapies. And also the FDA recently recommended for those with hepatic dysfunction, taking Tagamet to not go over 20. So, you know, when I first wrote this, these slides, I was concerned that when people heard this, they'd never use Celexa. I think the data is not robust in terms of the clinical efficacy of Celexa, and there are several additional things you have to think about before you take Celexa. So as a result, as a pediatrician, you may move it to your second-line SSRI and try the other ones that are, frankly, more simple and have more data. But I still feel that it belongs on the list because it has a role, and there are many people using this medicine and using it effectively. So I'm not recommending that you go out and use Celexa if you're not comfortable with it. But I also want to make sure that pediatricians know that it is an appropriate first line for some kids, especially those treated with psychiatrists or by others with more expertise, and that if you see Celexa being used, you should know about these things, but it doesn't mean that there was something inappropriate happening. So there are certainly situations where Celexa is quite helpful, and in fact, as I wrote this, I consulted a number of my colleagues who were concerned that I might remove Celexa. Because it has those histaminergic properties, it definitely has a role in helping a little bit with sleep in kids with anxiety that need an SSRI that's not activating, and also in helping with those belly pain kids. So it's not inappropriate, but because of these additional warnings, I would probably move it a little bit lower in my armamentarium than the other SSRIs. So we're through the initiation check, and then we go to the first SSRI check. So I wrote this protocol so you could do these checks in whatever way makes the most sense for the patient you're seeing and for your practice. So you should do this check within 1 to 2 weeks after starting medicine. You want to check for side effects, response. You want to, again, review expectations, goals, and safeties, and increase the medication if you started at a low dose. So this check could even potentially be done by a nurse or be done over the phone, especially if the child is seeing an outside therapist. I always start this check by reminding families that we don't expect to see clinical response yet. And in fact, things may even have gotten worse, and I want to know if they have. And I remind them this check is predominantly to check side effects, to assure safety, to get medication closer to a therapeutic dose, and have a check-in in case it appears that a higher level of care is actually needed. Because if things get much worse, you need to increase intensity of care even if you're starting medicine. There are a lot of words on these slides, but I essentially wanted to get everything on one slide so you could see that this is something that could be done relatively quickly and even be converted into an electronic medical record if need to be. So these are very specific questions you could ask to check for side effects, response, review goals, review safety plans, review expectation, and then increase medicine. So I am going to read through these. Are you concerned about side effects? Has anything changed that you're worried might be related to medicine? Have you had any thoughts about hurting yourself or anyone else? So notice I started at the beginning about their concern about side effects. I want to know what's changed, and then I specifically ask the child about thoughts about harming themselves or anything else. And then the next step is to check for response. Ask how the child is doing, have them potentially give a rating about how they feel, review the goals, are they still hoping to work on blank, and review the safety plan. It's nice to get a child to actually tell you what their safety plan is, and then also to find out if they've had to use it or how close they've come to using it. Certainly if you've had a child that's struggled with suicidality, this becomes even more important to know how close they've come to using their safety plan, or if their safety plan's ever failed. Finally, I review expectations, simply reminding them it's early to see an impact of medicine, but they should see some positive response in 2 to 4 weeks, and we look forward to your next check in 1 to 2 weeks when we'll increase medicine. So this is, again, to remind you what the part I just went through. You first check side effects, focusing on if they're concerned about side effects and specifically asking about suicidality. You check for response with the scale. So 1 to 10 scales have their ups and downs, frankly. They can be useful for internal consistency, but not between patients. But I do use this. I ask actually at the very first visit, and then again you can see for their internal consistency if anything's changed. And then expectations and increased medicine. And then review safety plans. And again, review expectations. And then we look forward to your next check in 1 to 2 weeks. And increase medicine. So that's the end of the first SSRI check. At that point, patients should be getting used to taking medicine, but they may not have any effect yet. The big difference with the second SSRI check is, which happens at 2 to 4 weeks after that first one, or 4 to 6 weeks after the original medicine was started, is that you may see response. So because of that, when I do this check, I actually start by assessing response. I ask how they're doing, and I even consider repeating original screens for target symptoms. Sometimes I wait if they don't think they feel better. Another important thing to notice about this visit is that at 4 weeks after starting medicine, there may be times that a parent notices changes in behavior or noticed improved mood, but the adolescent or child doesn't know anything. So I sometimes warn people about this, or at this visit I note that. So if the parent says, I notice they're a little better, and the child says not, I say, hey, this is not uncommon. A lot of times people around the patient notice that mood is improving or that outward behavior is improving before internal feelings actually change. And the rest of this is to check for side effects, again, review expectations, goals, and safeties, and increase medicine to a therapeutic dose. So third SSRI check is essentially a repeat of the second SSRI check. At this point, the child should be on a complete therapeutic dose for 4 weeks. So that's the point, if they had depression, that you should really start to see some response. Again, the child's internal feelings may lag behind what the family notes. If they're in partial remission, you want to keep increasing medicine. Defining full remission. So kids get better, adolescents get better. You want to make sure you get them to all the way better before you stop going up on medicine or stop escalating the type of treatment. So what is full remission? It's little or no evident impairment, little or no in their day-to-day activities. So they may still be working on goals, but they're not getting stuck on them. So, for example, the kid that couldn't go to school because they were anxious now is going to school. They still may have a lot of anxiety when they're in partial remission. When they're in full remission, they should be doing the simpler activities, such as just getting to school, without a lot of anxiety, and their anxiety should really only be escalating when they're purposely working on their fear ladders and doing things that they know they haven't been done before. So full remission does not mean no symptoms. For anxiety, it means that the symptoms should be not in the way and should not get in the way of them continuing to work through fearful things. There is a clinical definition of remission based on scares or GADs. Just as a warning, the GAD-7 should say less than 5. Sorry. It is very hard to get a GAD-7 less than 5. And for depression, it's a PHQ-9 less than 10 and no impairment. So what to do if a patient's not in remission? You want to increase medicine and/or therapy frequency, as I talked before, and you want to follow up for 4 to 6 weeks after each check, because you can increase medicine at each visit. You could also follow up earlier. You could even follow up at 2 weeks and increase medicine if they continue to not improve. So finally, once someone's in remission, they enter maintenance phase. And they should really have an SSRI check every 1 to 3 months during maintenance. At that point, you want to assess response, repeat original screens, and repeat original screens for target symptoms as needed. You want to check for side effects, continue to review goals, expectations, and safety plans, and begin to discuss when discontinuation will occur. So as soon as the child hits maintenance, I start talking about how long they're going to stay on medicine and what to expect through maintenance. A maintenance phase is typically 9 to 12 or 6 to 12 months of being in maintenance, and that's when you do discontinuation. So we extrapolate this from the depression literature. So the first episode of depression is 6 to 9 months of full remission. Second episode, you stay on medicine for 1 to 2 years, and after 3 episodes, you may stay on for life. So there are a number of children that will be on medicine for extended lengths of time, but if someone has only had 1 episode of depression, even if they have anxiety, I do try a discontinuation of the medicine after they've been in full remission for 6 to 9 months. I think this gets more complicated in kids that have depression and anxiety where their depression gets better and they stop any treatment other than medicine and they never work on their anxiety. So for those kids, I encourage them to really return to therapy prior to stopping medicine so they can work through the anxiety that may return. It is very therapeutic to do that, to work through the anxiety piece, and that's why I recommend it. So, discontinuation phase. You want to ensure that maintenance has occurred for enough time, meaning at least 6 to 9 months or even up to a year. I often say up to a year because you want to make sure you do it when you have the most success for doing it, and there's definitely evidence to suggest that stopping medicine in the middle of winter is a bad idea, not only for children but for adults too. So for many people that means continue on medicine until you get to the spring. In fact, for many of my children that I take off medicine in adolescence, we're doing discontinuation phase between the end of March and the beginning of May. You want to consider increasing therapy while decreasing the medicine. The rules of thumb for when to stop: do not do it before or during a great time of stress or change. And yes, you can do it if you've been in remission for 6 to 9 months. So you have your best success of increasing frequency of therapy and decreasing medicine slowly, i.e. Weekly or less. But remember, it takes 4 half-lives for medication to get out of the system and at least 4 weeks after that for a recurrence. So I warn families about this because it's not like you stop the medicine and the depression or anxiety is going to immediately come back, although with some you may get some side effects as it comes off. For some medications, it can take 8 to 12 weeks to see the full effect of being off the medicine. So another reason why I tend to do these discontinuations in the early spring. It's a good time because of the longer length of the days and more sun, but also there's a longer period of time until we get to the new school year, which is a stressful time for most kids. So I just want to take you back to the SSRI general information, reminding you of what a typical effective dose is, a typical dose range, the half-lives, and the half-lives of active metabolites. Again, reminding you how long fluoxetine is in your system. So, for example, for fluoxetine, if its metabolite is actually still active, so that means 4 half-lives is a very long time for the medicine to even get out of your system, and it may be still even having therapeutic symptoms 4 weeks after that. So important to stop fluoxetine relatively early. But it's also why you could stop, even if a kid's on a relatively high dose of fluoxetine, you could potentially just stop it because it's self-titrate. So I'd like to thank everyone for their time and thank Sherry Schaefer and Gretchen Crum for reviewing my slides, as well as all the therapists, pediatric primary care providers, and child psychiatrists who work with us to improve the lives of children and families in Western PA. Thank you very much.
This concludes our webinar. I want to thank Dr. Schlesinger for her excellent presentation. Many thanks again to the Pennsylvania Department of Health for the funding that made this behavioral health webinar series possible. Thank you.